Sanjeev, how are you?
Good evening, sir.
Good evening.
Good
Good
evening,
evening.
Dr. Vineet. Good evening.
Good afternoon. How are you? आज सिद्धार्थ एग्जाम लेने आए हुए हैं हमारे यहाँ
Yes, sir. So there are 4 candidates today.
4 candidates.
Namaskar.
नमस्कार सर.
How are you?
Good sir, all good.
Namaskar, Dr. Ramesh.
कोई बात नहीं, स्टार्ट कर लो यार.
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13th December 2000, of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22nd January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Good afternoon, one and all. I welcome you all to today's Navigate Medico CME program. I would now like to invite Professor Umesh Kapil Sir, the Secretary of National Academy of Medical Sciences, to deliver the welcome address.
Namaskar and good afternoon to all the speakers, resource persons, chairpersons, and all the participants. It's on behalf of National Academy of Medical Sciences. It's a proud privilege to welcome all of you. Navigate program was initiated. It's a national virtual graduate CME program. And this program was initiated all the postgraduates who are pursuing their MD courses, plus those who are in the most peripheral areas of our country and they would like to get into the NEET examination. So to update their knowledge, basically. It's a very humble effort of National Academy of Medical Sciences to reach the unreached doctors because there's hardly any CME activities for them. So what we are trying to do is that every month we have a CME program and we try to reach them through the Zoom. We also have this particular live telecast on the YouTube so that people can join. I can see from my IT section there are about 139 people who have joined on the YouTube. What we do is that we put up all the video recording of these sessions plus all the PowerPoints on the NAM's website. So it's a virtual library which we have. Right now we have about 60 virtual lectures which have been put up over there. Those who are interested in looking into the listing these sessions, again they can go back to it. We are very careful in selecting the speakers for this session. Most of them are the most eminent people in the country. I personally feel that Dr. Vineet Ahuja is a leading gastroenterologist in the field of gastroenterology, and he has been doing large amount of work, publications, immunology of inflammatory bowel disease for last 30 years. And he is working as a professor at the All India Institute of Medical Sciences, New Delhi. It's one of the most eminent institutions. We have our chairperson, Dr. Sanjeev Sachdeva, who is a professor, director professor with GV Pant Hospital, New Delhi. He would be moderating the session. And my humble submission is that all the participants, they should write their comments, they should write the questions in the chat box. Plus, they may have, it's very difficult and it's a privilege to ask questions from Dr. Vineet Ahuja and get the clarifications. So my humble submission is that please ask questions as much any doubts you have on inflammatory bowel disease and gastroenterology also with Dr. Sachdeva and Dr. Vineet Ahuja. With these words, I would like to again welcome all of you, Dr. Sanjeev Sachdeva sir, Dr. Vineet Ahuja sir. Thank you very much, sir. We are most grateful. Thank you very much. Over to you, Preeti.
Sir, I would now like to invite the chairperson for today's CME, Dr. Sanjeev Sachdeva sir, who is the Director Professor of Gastroenterology at GB Pant Hospital in New Delhi. Sir is the Vice President of Indian Neurogastroenterology and Motility Association, and his areas of expertise are small bowel bacterial overgrowth, tropical sprue, liver failure, endoscopy, and colonoscopy. His clinical research consists of authoring more than 100 peer-reviewed articles. It's an honor to have you here with us, sir. Over to you, sir, for your welcome address.
Thank you, ma'am, and thank you, Dr. Umesh and NAMS team for inviting me here. And starting from where Dr. Umesh left regarding Dr. Vineet, he is not just eminent or leading, he is, I would say, for me, greatest of all time. That is GOAT, just like Leo Messi for Argentina. He has done tremendous work in the field of IBD, taking India's name to global IBD platform. And his research areas of interest include fecal microbiota transplantation, use of latest biologicals, diet in IBD, which is a neglected topic all throughout in India as well as abroad, and also a lot of basic science work by Dr. Vineet. IBD, as we all know, in last 2 decades or so, has come up as exponential science in gastroenterology. We can see rising number of publications in not just gastroenterology journals or endoscopy journals, but also basic science journals and internal medicine. It will be difficult task for Dr. Vineet to cover entire IBD in 1 hour or 1.5 hours, but we expect the master to do the same. Welcome, Dr. Vineet.
Okay. Thank you very much, Sanjeev. I'm really humbled by your kind introduction. Thank you, Professor Kapil. And I would also like to thank Professor Sareen. Grateful to both of you for inviting me to give this lecture. Sanjeev, I'll share my slides and I'll start straight away. So, can you see my slides, please?
Yes, sir.
Yes, sir. Yes, sir.
Okay. So let us try to cover as many aspects of inflammatory bowel disease as possible in an hour. When we talk about inflammatory bowel disease, we're essentially talking of two components. One is, or you can say the spectrum consists of two kinds of diseases, ulcerative colitis and Crohn's disease. They're both immune mediated chronic inflammatory conditions of the intestine. Ulcerative colitis, as the name implies, it is inflammation of the colon, and so it remains restricted to the colon, whereas Crohn's disease can affect any part of the gut from mouth to anal canal. Besides that, we have two other terms, IBD unclassified and indeterminate colitis. In 10% of cases, sometimes it is very confusing. It is difficult to differentiate whether the patient has ulcerative colitis or Crohn's disease at the onset. And this categorization may not be possible even after doing all the investigations like radiological investigations, endoscopy, and histology data is also available. Then it is known as IBD-U or IBD unclassified. And when this categorization is not possible, even after the colectomy specimen is available, then it is termed as indeterminate colitis. Why this is important? This is important because IBD unclassified and indeterminate colitis may not behave in a similar manner as a case of ulcerative colitis after surgery. So that is why you have this subcategory is also very necessary. Has IBD disease burden increased in the country? Is it increasing? Yes, definitely. It seems that ulcerative colitis and Crohn's disease are being seen very commonly in the country. Probably there has been an increase in the disease burden, or likely also that many gastroenterologists, physicians are more aware of the disease. The ability to diagnose is better in terms of the colonoscopic facilities are more widespread. So as a result, what we see that earlier USA was considered to be the disease capital of the world, and USA was thought to have maximum number of cases. But over last 2 decades, we have seen that the burden of IBD has shifted towards the east. It has pivoted to Asia. So much so that India possibly would be having around 1.5 to 2 million cases of IBD today, which is amongst the largest in the world. If in a very simplified manner, I have to tell you what causes IBD, then the first statement is that we really do not know what causes IBD. However, if we look at a hypothesis, then we find that in genetically predisposed individuals, there is an aberrant immune response. This aberrant immune response may be to the commensal bacteria or to some certain environmental factors of which diet could be playing a main role. And this inflammation occurs at the epithelial level in ulcerative colitis and may extend transmurally in cases of Crohn's disease. So this is the most simplified way in which I can put the pathogenesis of IBD. And why is it important? It is important because obviously then you have to look at what factors you can modify out here when it comes to treatment. Regarding clinical approach to a patient with IBD, there are 6 points we need to be aware of before we start managing a case. And this is true for both ulcerative colitis as well as Crohn's disease. The first point is that you should be sure about the diagnosis. Is it ulcerative colitis? Is it Crohn's disease? Or is it IBD unclassified? What is the duration of the disease? What is the extent of the disease? What is the phenotype of the disease? Are there any extra intestinal manifestations? What is the disease activity at present? And what has been the prior treatment record? All of these factors are going to play a role in your deciding the further management for this patient. So whenever you are going to start a treatment or you're going to decide how you're going to change the treatment, these 6 factors are very important and they should be clearly written on your card. Now, there is no gold standard for diagnosis of IBD, and that is where the problem starts. If there was a gold standard, then it would have been very easy to categorize a patient as having ulcerative colitis or Crohn's disease. Let us say, for example, for tuberculosis, you have a gold standard. You would say that culture positive, you know that. For MTB positive, you know the patient has tuberculosis. But for IBD, no single test exists. So, how do you make a diagnosis of IBD? Diagnosis is established with the help of compatible clinical features, lab features, imaging features, endoscopic features, and histopathology. And at the same time, you rule out other causes, and principally among them are the infective causes. They need to be ruled out. Repeat endoscopy with histopathological review after an interval may be necessary if diagnostic doubt remains. So, in this way, you can say that since inflammatory bowel disease is idiopathic, so the diagnosis is also by exclusion. For example, when we come across a case of ulcerative colitis which comes with first presentation, obviously the differential out there is whether the patient has acute self-limiting colitis or what I do known as acute gastroenteritis or bacterial or viral or amoebic enteritis. So how do you decide whether the patient has ulcerative colitis and you need to start a patient on steroids or 5-aminosalicylic acids, or the patient has simply infective colitis, no chronic inflammation like ulcerative colitis, and the patient will benefit with antibiotics. So let's say there's a 25-year-old young male comes with increased frequency of stools for 2 weeks, only 2 weeks history. So since there is no long duration of symptoms, so it does not make you wiser, 6 to 8 times per day, 2 to 3 times per night, blood and stools, urgency and tenesmus present. You do a sigmoidoscopy, you do find some ulcers out there. So how do you decide whether this patient has infectious colitis or ulcerative colitis? Duration of disease is helpful if there is a long duration. That makes the job much easier. If the patient comes with a history of 2 years, history of waxing and waning symptoms. Thrombocytosis is a soft point. Thrombocytosis is often seen in patients with inflammatory bowel disease, whereas not seen in patients with infective colitis. Stool cultures are often not useful. Fecal calprotectin is a test which measures inflammatory markers in the stool. I'll talk about it later, but fecal calprotectin would be raised in any infectious or inflammatory condition. Calprotectin is released from neutrophils. So wherever neutrophils get lyse and are released in the stool, then calprotectin is released in the stool, and so it will not be useful. Sigmoidoscopic picture again is not very useful, but biopsy is something which can help you to differentiate infectious colitis from ulcerative colitis. What changes in biopsy would you look for? You're looking for distorted crypt architecture, the destruction of the crypt architecture, and some amount of also basal plasmacytosis. Why is it so? Because crypt architecture destruction is a sign of its chronic, that means the disease is chronic in duration. Similarly, basal plasmacytosis has been recognized as the earliest feature with the highest predictive value for diagnosis of ulcerative colitis. So even if the patient has first episode of ulcerative colitis, basal plasmacytosis can develop in the biopsy specimens within 2 weeks. Whereas crypt architecture distortion may take 3 to 6 weeks to develop. So if you find in a biopsy specimen basal plasmacytosis, you know you're dealing with a chronic inflammatory disease, and rest of the features match, then you know it's ulcerative colitis. Similarly, if you find crypt architecture destruction, then you know that you're dealing with a case of IBD out here and not infectious colitis. So in this setting, one is the use of biopsy, but at times GI pathologists are not available or these changes are not found in all biopsies. Then what do? You give a course of antibiotics, repeat sigmoidoscopy after 2 to 3 weeks. If the patient is sick and not responding to antibiotics, then at times 5-ASA has to be added. Occasionally, steroids also have to be added, although one would try not to do that. But repeating a sigmoidoscopy after 2 weeks or less than that and by repeating the biopsy is the key to differentiate infectious colitis from first episode of acute ulcerative colitis. There's a Montreal classification for both ulcerative colitis and Crohn's disease, which determines the phenotype of the patient. And for ulcerative colitis, the Montreal classification essentially has one component, that is disease extent, E1, E2, and E3. E1 is where the disease is limited to 15 centimeters from the anal verge, involving essentially the rectum. E2 is when the disease is limited till the splenic flexure. It is known as left-sided colitis. E3 is when it extends behind the splenic flexure, then it will be extensive colitis or pancolitis. Now, this is defined by the maximal macroscopic extent, not the microscopic extent. Based on the extent as seen on colonoscopy. So you can classify a patient as having proctitis, left-sided colitis, and or extensive colitis, that is E1, E2, or E3. Remember that in ulcerative colitis, the disease involves only the mucosa. It's not a transmural disease. However, the disease has one characteristic. It can go progress longitudinally or regress longitudinally. In other words, the extent can be proctitis to start with, and in 20% of patients, it may extend on to left colitis or pancolitis. Similarly, it can regress also, that in 20 to 30% of patients who present with pancolitis, ultimately the inflammation may settle down to proctitis or left colitis. So this kind of progression and regression phenomena can be seen. And this is again important because when you're treating a patient with ulcerative colitis, the patient presented with proctitis, you feel the disease is very limited and the patient is going to respond well. However, subsequently you see the patient is not responding well, and you do a repeat sigmoidoscopy or colonoscopy and you realize now the patient has pancolitis or extensive colitis and requires that kind of management. When you do a colonoscopy, it is very important also to assess the endoscopic severity of ulcerative colitis. This is again important because not only the score has a prognostic value, but it also helps you to objectively evaluate the patient in subsequent visits. Most common index of severity which is used is ulcerative colitis endoscopic index of severity, or also known as UCIS. It is based on three parameters, that is loss of vascular pattern, bleeding, erosions, and ulcers. A total score of 8 is given, where a score of 4 or more than 4 would suggest that the patient is moving towards moderate disease and more than 6 is towards severe disease. And when you do colonoscopy, you obviously take biopsies. In biopsies, you're looking for acute changes as well as chronic changes. Aberrant abnormal crypt branching is a chronic change which tells you that there is chronic inflammation, whereas ulcerations and crypt abscesses tell you that there are a lot of acute changes which are taking. In cases of ulcerative colitis, you also have goblet cell depletion leading to mucodepletion. The changes which are suggestive of ulcerative colitis would be goblet cell depletion, widespread mucosal or crypt architectural destruction. Changes of chronicity would be focal or diffuse plasmacytosis, Paneth cell metaplasia. Crypt architecture destruction is also a change in change of chronicity. Acute injury changes would comprise of neutrophils within the crypt epithelium and crypt lumen. If there are cryptitis and crypt abscess, that means the disease is active. If the patient has only crypt architecture destruction, no neutrophils at all, that means that histologically the disease is not very active. That is a very good sign. What kind of imaging you would like to do in a patient with ulcerative colitis? Since the disease is limited to colon, most of the times you do not have to resort to a CT scan unless and until you're suspecting perforation or if the patient is having a toxic megacolon. Toxic megacolon is when the transverse colon is dilated to more than 6 centimeters. It is picked up on abdominal x-rays, and if you want to rule out a perforation thereafter in the subsequent events, then a CT scan would be required. The other time when imaging is required is when there is a diagnostic confusion with Crohn's disease. That is the time a CT or MRI or a cross-sectional imaging would be required, because you would like to find out whether small intestine is involved or not, which would help you to distinguish between both the diseases. What kind of imaging you would like to do? Often people do in such settings end up doing a CCT abdomen, that is a CT abdomen with a positive contrast. Remember that if you want to evaluate the bowel changes, then best is to do a CT enterography. CT enterography is nothing but again a CT scan where a negative or a neutral contrast is given. Either mannitol mixed with water or polyethylene glycol is mixed with water, and that is given in around 1.8 liters of is given so as to distend the small bowel as well as the large bowel, so that you can look at any strictures which are there. You can also look at mucosal changes. The presence of IV contrast would help you to also look at whether there are any signs of inflammation. As you can see out here that these segments are inflamed. There's a sign, comb sign, which is seen often in case of Crohn's disease. But now, right now, we're talking of ulcerative colitis. And ulcerative colitis, you will only do a CT enterography if Crohn's disease is suspected, or sometimes you end up suspecting for toxic megacolon, as I told you, but then you will not do a CT enterography, but a simple CT abdomen with a positive contrast if you're suspecting toxic megacolon. Role of serology, ASCAND, ANCA, have poor diagnostic accuracy. They're expensive tests. It's not necessary to send them in any every case of IBD because they have poor discriminant value in differentiating Crohn's disease from ulcerative colitis. They have value, ASCA has value in picking up small bowel Crohn's disease. But then if there's small bowel involvement as it is, you would not entertain a diagnosis of ulcerative colitis. So just to differentiate between ulcerative colitis from Crohn's disease, ASCA and ANCA do not have much role. So when mapping out the disease activity of ulcerative colitis, we can map it clinically, we can map it endoscopically, as I've shown you with the help of ulcerative colitis endoscopic index of severity. And now we have non-invasive tests like fecal calprotectin, which can also help you to determine disease activity. Clinically, how do we map it? We can map it with simple scores. There is a score known as True-Love and Witch score, which is available, which is based on two symptoms, that is the number of stools and blood in stools, two signs, pulse and temperature, and two simple bedside investigations like hemoglobin and ESR or CRP. Any one of them can be done. And if the patient has more than 6 bloody stools with any of these 4 features, temperature, hemoglobin, ESR, or pulse raise, then you know that the patient is having acute severe ulcerative colitis, or that is an indication for admission. Similarly, there's another score which is available that is known as Mayo score, that is very frequently used, which is based on 4 features: stool frequency, blood and stools, findings on endoscopy, and physician's global assessment, with a total score of around 12, and anything from 9 to 12 is considered as a severe disease. Fecal biomarker, as I've already told you about calprotectin. Calprotectin is a protein in the cytoplasm of neutrophils. So whenever there is a neutrophils which are there in the bloodstream, go to the lamina propria, which is the site of inflammation. If there is ulceration, there is transepithelial migration. The neutrophils get lysed. The calprotectin gets released in the feces. Calprotectin is a very stable protein, so it can remain stable in the feces. So subsequently, a stool test can measure the level of calprotectin, and high calprotectin has been found to be very useful to differentiate inflammatory bowel disease from a functional disease like irritable bowel syndrome. At the same time, even in inflammatory bowel disease, calprotectin levels can help you, or they correlate with mucosal healing, that is endoscopic healing. They correlate with mucosal healing as well as histological healing. So they are good non-invasive tests by which one can monitor a patient if the patient does not want to undergo a sigmoidoscopy repeatedly and the symptoms are such that you're confused whether the patient is having active disease or non-active disease. IBD patients do have extraintestinal manifestations, around 20 to 30% of them, and this data from India shows that majority of the most common extraintestinal manifestation is an arthralgia, which may be a peripheral arthralgia or a central arthralgia. Ankylosing spondylitis is seen, dermatological manifestations are seen, eye changes are seen. Primary sclerosing cholangitis, although not very common, can be seen in around 0.5% of the cases. And these EIMs are seen in both ulcerative colitis and Crohn's disease, although slightly more common in patients with Crohn's disease. So we have discussed the phenotype of a patient with ulcerative colitis, the main points you need to look at before you decide how you're going to treat that. Now let's discuss about the phenotype of Crohn's disease. That if you have diagnosed a case of Crohn's disease, what all do you need to know about it before you start management? Crohn's disease has a progressive behavior. It starts with an inflammatory phenotype, can move over to a stricturing phenotype, and can move over to a fistulizing phenotype. It's a progressive disease transmurally. As I told you, ulcerative colitis could have progression or regression longitudinally. In Crohn's disease, the progression would be transmural. So the phenotypical classification, again, the Montreal classification for which was there for ulcerative colitis, which had only looked at the extent. Here, it looks at 3 factors: the age at diagnosis, the involvement, site of involvement, and the behavior. So it will have 3 components: A, L, and B. A1 is less than 16 years age at diagnosis. A2 is 17 to 40 years. A3 is more than 40 years. The location is L1, that is a terminal ileum, which is seen in 1/3 of the cases. L2 is colon, which is seen in around 20 to 30% of cases. Iliocolonic is seen in 20 to 30% of the cases. L3, L4 is only involving the upper GI tract, or you can say anything which is proximal to the ileum. So L4 is slightly uncommon as compared to L1, L2, and L3, and you can have various combinations, that is L4 with L1 or L4 with L2, etc. Similarly, behavior is starting as an inflammatory disease, B1. It can move over to stretching disease. It can move over to fistulizing disease, or they can be standalone perianal fistulas. Sometimes Crohn's disease can be so aggressive that it can straight away present as a perianal fistula or a fistulizing Crohn's disease or stricturing Crohn's disease. So 20% of patients of Crohn's disease progress within the first 5 years of diagnosis, as this graph shows that B1 moves over to B2 and B or can move over to B3. So why this is important? This is important that because if you can arrest the progression of disease, you can change the disease. So this has to be kept in mind that since Crohn's disease is progressive and aggressive, so if you want to change the disease course, you have to stop this progression, and that is very important. For example, this graph again shows disease onset, disease diagnosis, early disease. Thereafter, the disease becomes more and more complicated. So this is the window of opportunity out here when there is early disease, whereby if you diagnose early and at the same time institute the proper treatment, you may be able to bring the disease into remission, and that would be really helpful for the patient. The main differential for Crohn's disease is tuberculosis. In our country, this is quite a problem, not only in our country, I would say, but in other South Asian countries. Tuberculosis and Crohn's disease are phenotypically similar. Whereas in Asia, South Africa, you not only have cases of tuberculosis, but you also have cases of Crohn's disease, because the epidemiology of disease has been such that the infectious diseases have not gone away and the other non-communicable diseases have coming up. In USA, they do not see so many cases of intestinal tuberculosis, so they don't have this problem. In Europe, they don't have so much of this problem. Now, the second point why this is a problem is because intestinal TB is possibacillary. Pulmonary TB is multibacillary. So the same test which would pick up pulmonary TB very easily, in the sense you send a sputum sample and you pick up AFB, that same test will not be so sensitive in a case with intestinal TB because it's possibacillary. So the sensitivity of the test would be very poor. So again, the gold standard tests which are used to make a diagnosis of TB would not do so well when it comes to intestinal TB. And as we already know that Crohn's disease again relies on exclusion. It does not have a definite gold standard test. So there the problem arises where both these diseases which have the same presentation can be seen, and then you have to decide how to treat them. And as you know, the treatment can be radically opposite. For a case of tuberculosis, you need to give antitubercular therapy. For a case of Crohn's disease, you have to give immunosuppressive therapy, and obviously you cannot confuse between the two because that can have disastrous consequences. So how do you decide when you do not get a gold standard test positive for intestinal TB? You decide that based on history clues which you get. Clinical is that is the clues you get on history. Do an endoscopy, pick up some clues. Histology, pick up some clues. Image the patient with the help of CT or MR enterography, pick up some clues, and then there are certain adject tests. When we talk about history, we find that shorter duration of disease favors tuberculosis. Diarrhea, hematochezia, perianal disease, extraintestinal manifestation, they favor Crohn's disease, right? Again, I'm using the word favor because if a patient is having diarrhea, it does not mean that the patient cannot have tuberculosis. It's just that more cases of Crohn's disease would present with diarrhea than cases of tuberculosis. Perianal manifestations are seen in, let's say, 10 to 20% of cases of Crohn's disease, but they are also seen in 1% of cases of tuberculosis. So it is not a all or none law. It is just that it gives you soft points by which you can decide, okay, possibly the probability of this disease is higher or Crohn's disease is higher if the patient has diarrhea, hematochezia, or perianal manifestations. For example, this shows the extraintestinal manifestations in Crohn's disease and TB. It is not that extraintestinal manifestations do not occur in TB and they occur only in Crohn's. This is data from India, which shows that even in 8% of TB patients, you may have peripheral arthropathies. You can have any EIM or any extraintestinal manifestation in 14% of patients of TB, although the same figure would be 38% in a case with Crohn's disease. So that is what we mean when we say favors. It tells you that yes, this thing is more common in a certain disease, but doesn't mean that it cannot occur in the other disease. Similarly, when we do a colonoscopy, we find that longitudinal ulcers are more frequent in cases with Crohn's disease. Cobblestoning is more frequent in Crohn's disease. Aphthous ulcers are more frequent in Crohn's disease, and perianal lesions are more frequent in Crohn's disease. Whereas in tuberculosis, Strictured or patulous IC valve is more common. Involvement of colon is more than less than 4 segments is more common in tuberculosis, and ulcers are transverse in tuberculosis. But again, these are all soft points. Another interesting point is that in Crohn's disease, it's more likely that you may have a diffuse involvement, that is left as well as right-sided involvement, which is seen much less in cases with Crohn's disease. In tuberculosis, you would have mainly either right-sided involvement or a single segment involvement, whereas many segment involvements, if they are involved, it favors a diagnosis of Crohn's disease. Again, a soft point. When you take biopsies, macrogranulomas, that is granulomas more than 400 nanometer, confluent granulomas, multiple granulomas, multinucleated giant cells in granulomas, and caseating granulomas. These are features which help to make a diagnosis of tuberculosis, especially caseating necrotizing granulomas. They favor a case of tuberculosis. Caseation is essentially seen in tuberculosis. Caseation is never seen in a case of Crohn's disease. In Crohn's disease, you may have microgranulomas, you may have granulomas which are not confluent, and obviously they're ill-formed granulomas, or there will be non-caseating granulomas. You can do a Zn stain, you can look for lymph nodes, etc. But again, as I told you, the sensitivity ranges from 5 to 20% depending upon the series. Would PCR be helpful? Well, PCR, a simple PCR would be less sensitive because other members of the MTB complex can also give a positive test, and PCR should not be used, especially in intestinal TB, to make a diagnosis and differentiate it from Crohn's disease. It should be PCR positive. PCR should be interpreted in light of other clinical, endoscopic, and histological findings. Yet at the same time, again, a nucleic acid amplification based test like Gene Expert or CBNAT cartridge based NAT is very useful for making a diagnosis of TB. Why? Because it may not be very sensitive. It has poor to moderate sensitivity, but it has an excellent specificity. It has a specificity for ranging from 97% to 100% to make a diagnosis of TB. So if you are going to use a PCR-based technique, then use Gene Expert or CBNAT. That would be really helpful, but not a simple TB PCR. Crohn's disease needs to be imaged because you need to determine the extent of the disease. It may not have only large intestinal involvement, so only colonoscopy is not sufficient. Here you have to do cross-sectional imaging, and the best cross-sectional imaging which can be done today is CT enterography or MR enterography. It has replaced barium studies all through because CT is available at many centers now, and so it can be done. If it's a pediatric patient or where you are having multiple imaging being done at frequent interval, then MR obviously would be preferred because it is radiation free. Otherwise, generally people prefer to do a CT angiography first because it is much more easy to decipher and it helps in putting down the roadmap in position. In Crohn's disease, you can see multiple segment involvement, you can see a long segment involvement, you can see mural stratification where you can see all the layers of the small intestine or the large intestine. There may be fat proliferation, increased adiposity, there may be pseudocirculation which may be there, or enteroenteric fistula can be seen. Again, can these features not be seen in tuberculosis? These features can also be seen in cases with tuberculosis, but there is only one feature which can actually help you to differentiate tuberculosis from Crohn's disease, and that is presence of necrotic lymph nodes. Necrotic lymph nodes can occur in malignancies also, can occur in lymphoma also. But again, remember, when the setting is to differentiate tuberculosis from Crohn's disease, then in that particular setting, a necrotic lymph node would favor tuberculosis very, very strongly as compared to a diagnosis of Crohn's disease. Besides that, another feature which we can take into account is the presence of fat trapping. Now, Burrell Crohn, the person on whose name the acronym or the Crohn's disease, the name, on whose name Crohn's disease has been kept. In fact, he first account only they described about a lot of creeping fat which was seen in cases of Crohn's disease. This creeping fat has not been seen so much in cases of tuberculosis. So, based on that, whether you can differentiate, then you see that if you look at visceral fat and if you look at subcutaneous fat, then visceral fat or subcutaneous fat as the ratio which can be measured in any CT scan at the L4 vertebral level, the ratio of this visceral fat and subcutaneous fat is much higher in patient with Crohn's disease. Why? Because there's a lot of fat trapping, a lot of mesenteric fat, so visceral fat is much higher. So if the ratio is more than 0.63, then it has a high sensitivity and specificity to make a diagnosis of Crohn's disease. Similarly to that, if we add long segment involvement, that is, we know that patients with Crohn's disease have long segment involvement. Along with that, we know that they have increased visceral fat. So if you make a index which combines both visceral fat as well as long segment involvement, you find that it is almost exclusive for Crohn's disease, and it can differentiate Crohn's and TB with excellent specificity. In such a setting, also, when you're trying to differentiate Crohn's from TB, generally chest X-ray is done so as to rule out concomitant pulmonary TB, because if pulmonary TB is present, it makes making your diagnosis much easier. It makes your job much easier. However, it has been seen that if you do a CT chest, it may be much better to do a CT chest in this setting, as it increases the sensitivity of diagnosis by at least 30%. So in such a setting, it may be preferable to do a CT chest rather than chest X-ray, as it helps you in making a conclusive diagnosis. ASCA and ANCA2 serologies, which have been used often, as I told you, for making a diagnosis of Crohn's disease and ulcerative colitis, and ASCA especially for Crohn's disease. So people have also done studies whereby they have looked at ASCA and tried to differentiate whether it can differentiate it, positive ASCA can differentiate Crohn's from TB, and you find two studies out here which show that ASCA cannot differentiate between Crohn's disease and TB. So no point doing that study. Interferon gamma release assay is a test of latent TB. It's not a test of active TB. So again, doing interferon gamma release assay and basing your diagnosis just based on mere positivity of interferon gamma release assay to make a diagnosis of TB is also not right, as the study shows that interferon gamma release assay has a very poor sensitivity and specificity to make a diagnosis of active TB. So this test should not be used to make a diagnosis of active TB. So if I compile everything together, we find that there are certain clues: diarrhea, hematochezia, perianal manifestations, longer duration, extraintestinal manifestation favor Crohn's disease, left as well as right side colonic involvement with longitudinal ulcers, aphthous ulcers, and cobblestoning favors Crohn's disease, whereas ileocecal valve involvement, transverse ulcer favors TB, microgranuloma favors Crohn's disease, large caseating confluent granulomas are very suggestive of TB, long segment involvement, increased visceral fat favors CT, whereas necrotic lymph nodes favor TB. And CT chest is again very helpful in making a diagnosis of TB. Besides that, HIV, TST may be done, but again, they are just useful. So what happens is that most of these patients, 30% of these patients, I would say, you end up giving a trial of anti-tubercular therapy because you're still not sure whether the patient is having tuberculosis and Crohn's disease. So what happens when you give them an anti-tubercular trial? What happens? So obviously the immediate response would be that patients of tuberculosis would respond to anti-tubercular therapy, whereas patients of Crohn's disease would not respond to anti-tubercular therapy, and so you'll be easily able to distinguish between the both. Does it happen? No, it does not happen so. Because in this study, you find that when patients who were eventually diagnosed to have Crohn's or TB, but were given ATD trial because initially the gold standard tests were not positive, at 3 months, although 93% of TB patients they responded, 38% of Crohn's disease patients also showed a clinical response. At 6 months of anti-tubercular therapy, 37% or one-third of patients of Crohn's disease were showing a response to anti-tubercular therapy in form of clinical improvement. So how do you differentiate? Well, you go and do a colonoscopy because you look for ulcer healing. And when you look for ulcer healing, there the distinction comes up because patients of tuberculosis, almost 100% of them had ulcer healing, and the only remnants left were pseudo polyps or scarred healed ulcers or something like that in 100% of cases. Whereas in Crohn's disease, 87 or 95% of them did not show any response. The ulcers did not show any response, even though there was a clinical response. So you have to document not only symptomatic response but also mucosal healing if you want to make a diagnosis of Crohn's disease in a patient who has been given a trial of anti-tubercular therapy. And so on the basis of which the Asia Pacific guidelines have been made, whenever there's a diagnostic confusion, you start ATT, look for clinical response. If there's a clinical response, you keep on following up the patient, but at the end of 6 months, you have to document mucosal healing with clinical response if you want to make a definite diagnosis of Crohn's TB. However, if the mucosal healing has not occurred, then that means either it is Crohn's disease or it could still be MDR TB, so you take biopsies. If the patient is not doing well at 2 months or 3 months, then immediately you would like to repeat a colonoscopy and look for possibility of CT. At the same time, the issue came up that since patients seem to be responding to antitubercular therapy, is it possible that some of the patients who respond to antitubercular therapy in the long term, they would do well? The disease course of Crohn's disease would be much, much more benign. So they looked at these patients who have a case of Crohn's disease, who had initially an ATT trial when the diagnosis was made, or some patients of Crohn's disease where the ATT trial was not there. The diagnostic delay was equal in both the groups of 24 months. And surprisingly, all those patients who were given a trial of antitubercular therapy, when they were followed up, it was seen they had a higher chance of developing stricturing disease. They had a higher chance of undergoing surgery. And this risk of progression, that is moving over from B1 to B2 disease, inflammatory to structuring disease, appear to be conferred only by antitubercular therapy itself rather than the diagnostic delay occurred due to ATT. In other words, tubercular therapy, antitubercular therapy is possibly fibrotic. So it was inducing fibrosis. As a result, these patients were undergoing they had a higher chance of surgery. So the algorithm had to be revised, whereby now we've revised the algorithm and now it states that whenever there's a diagnostic confusion between Crohn's and TB, you start ATT. Despite the clinical response at 2 months or 3 months, still repeat a colonoscopy. Don't wait till 6 months. At 6 months, if you repeat a colonoscopy and if you find that the ulcers are healing, then it is TB. If the ulcers are not healed, you take a biopsy, rule out MDR TB, and consider that this has possibly Crohn's disease. This would allay the fibrotic effect of antitubercular therapy. So Crohn's and TB are very alike. You can distinguish between them with the help of certain features which are helpful or soft features like long duration diarrhea, hematochezia, left-right colon involvement, large caseating granulomas, lymph nodal necrosis. PCR is not helpful. Gene expert is helpful. But when you give ATT trial, look for not only the symptomatic response but also mucosal response. In Crohn's, mucosal response will not occur. In TB, both mucosal and symptomatic response will occur. And do a colonoscopy at 8 to 12 weeks. Okay, so now we have discussed what we need to know about a case of ulcerative colitis or a case of Crohn's disease before we move over to management. How to diagnose them, what is the most common differential, and what essential investigations have to be done so that we can chart out what is the extent of disease, what is the location of the disease, what is the severity of the disease, and thereafter we can move over to management. And management, remember that these are chronic lifelong illnesses, so they need to be treated on for a very long time, and so there would be a phase where you would induce remission and subsequently maintenance of remission has to be done, because otherwise the patients would have frequent relapses. So if you look at the treatment pyramid for IBD, you find that there are essentially the drugs consists of immunosuppressants, immunomodulators, the topical immunomodulators, or biologicals or surgery, and that is in a way you can say a therapeutic pyramid for IBD. So before we go into specific treatment or specific thing, I think first we should again have a broad understanding of what agents are used for treatment of IBD, and then we can move over to specific cases. In a case with ulcerative colitis particularly, it is very important that topical therapy is added in every case practically, regardless of the extent of disease. Why is it so? Because rectum is the most common site of inflammation. And oral drugs possibly may not achieve the most potent effect or beneficial effect at the site of rectum as compared to suppositories, foams, and enemas. So, if there is rectal involvement and you want to decrease the rectal inflammation, suppositories are very useful, but suppositories do not extend are not effective beyond 15 centimeters, whereas foams reach till the sigmoid colon. And enemas, that is 70 ml enema, 100 ml enema, the more the quantity of liquid in the enema, they extend up till splenic fracture. So orally given tablets of mesalamine would be released more in the right colon, the transverse colon. Suppositories would be most effective in rectum. Foam enemas and liquid enemas would be more effective in sigmoid and left colon. And topical therapy is very successful in cases with ulcerative colitis. Second is 5-ASA is used, one of the mainstays for which is used for treatment of ulcerative colitis. And even though in Crohn's disease, evidence does not fully recommend use of 5-ASA, still in mild Crohn's disease, many patients do respond very well to 5-ASAs. But again, you have to be clear that 5-ASA, many kinds of preparations are available. Depending upon which side the disease is involving, you have to use that 5-ASA. If it is Crohn's involving the small bowel and you want it's a very mild disease, few abscess ulcers, and you want to start 5-ASA, then you have to use mesalamine delayed release capsules. Whereas if it is involving the terminal ileum, then you can use mesalamine pH sensitive release capsules. If it is involving then ulcerative colitis, you can use mesalamine pH sensitive release capsules, or you can also use sulfasalazine, which is deconjugated in the colon, so its maximum action is in the colon. So 5-ASA optimization, remember that there's a drug delivery site and you have to be aware of that. Second, steroids, often used. Now, steroids initially, the first generation steroids were basically the systemic glucocorticoid therapy. That would be intravenous corticosteroids or the oral corticosteroids like prednisolone. Now, prednisolone has only a 20% first pass effect and it is distributed actively throughout the body. Came up the second generation, the newer generation steroids, which is the budesonide. Now, budesonide, two kinds of preparations are available. One is known as the controlled release preparation, the other is known as the multimatrix or MMX preparation. So, budesonide, regardless of whether it is controlled release or MMX, there is the first pass effect is around 90%. So, what is the benefit of that? The benefit of that is that it will not cause potent HPA axis suppression. So, the side effects would be less. But at the same time, what do you have to remember? You have to remember that it will only have a topical effect. It will not be distributed throughout the body. If it is getting released somewhere in the lower small intestine and all, so as a result, it will be active in those areas only. Budesonide is available in a dose of 9 milligrams and prednisolone is started with a dose of 40 milligrams. So a budesonide MMX would be released mainly in the colon. So if you are going to treat a case of ulcerative colitis, you would like to use budesonide MMX preparation. Whereas if you are going to treat a case of, let us say, small bowel Crohn's, then you would like to start a case with budesonide controlled release preparation. This confusion should not, should be clear in your mind and there should be no confusion about that. Another very important drug which is used is azathioprine. Azathioprine is often used when there is a steroid dependent state that a person is on steroids, is not responding to steroids, or he has responded to steroids, and when the steroids are tapered off, then as a result there's a relapse. Azathioprine is an excellent drug for resource poor areas because why? It is cheap, it is not expensive at all, and at the same time 40 to 50% of patients have a very good response to it, both patients of ulcerative colitis and Crohn's disease. The only thing is that when you start azathioprine, you have to do it very carefully. Azathioprine is associated with leukopenia. There's myelotoxicity. There can be thrombocytopenia and hepatotoxicity also. Azathioprine undergoes metabolism, and when it undergoes metabolism, it is dictated by two genes, TPMT and NUDT, of which in Asians, NUDT15 polymorphism is much more important than TPMT. So best is the pharmacogenomic approach that you look at NUDT15. If it is normal, then maybe you can start with full dose of azathioprine, and if possible, also check for TPMT. But again, these tests are not available everywhere, and it may be difficult also because in the sense they're expensive tests. So an easier approach could be a step-up approach. You start with small doses. The dose of azathioprine is 2 to 2.5 milligram per kg. You start with small doses, 25 or 50 milligram, and gradually increase the dose, but monitor CBC every 2 weeks, 4 weeks, so that you can stop immediately if there is any sign of myelotoxicity. 6-mercaptopurine is a prodrug which can be given at the dose of 1 to 1.5 milligram per kg. Azathioprine takes a long time to act. It takes around 3 months before the whole action can kick in. So don't be in a hurry to stop it if within 1 or 2 months there is no response. You optimize your therapy by increasing dose to 2.5 milligram per kg. In cases where there is hepatotoxicity, you can add allopurinol and decrease the dose of azathioprine to 25 to 50 milligram per day. You can give azathioprine to 4 4 to 7 years or even beyond that after discussion with the patient. Why don't you want to give it for a long time? Because there is a risk of lymphoma, although that is not, the risk of lymphoma is not very high. It is marginal or small, but nevertheless it is there, 1 in 10,000. So that is why you are hesitant in giving very long duration of azathioprine. So coming back to the pathogenesis, because we are now going to talk about advanced therapy. Now, as I told you that you have to modify one of these circles if you want to treat a patient, and obviously aberrant immune response is the one where most of the work has been done. The other place where work is going on is manipulation of the microbiome, since there is dysbiosis out there. So fecal microbial transplantation has been done, but still it has not been approved by the regulatory agencies. So I'll restrict to the agents which are available in the country, that is immune agents which modify the immune responses. Or in other words, after obviously steroids also modify the immune response, azathioprine also modifies the immune response. But what happens when azathioprine and steroids have been used and still the patient is not responding? What do you do? The first class of drugs which came up, or these are all monoclonal antibodies, are anti-TNF blockers, TNF alpha monoclonal antibodies. TNF is produced by macrophages. It is also produced by the lymphocytes. So TNF is a major cytokine which produces inflammation. So if you have a TNF inhibitor, it would eliminate or neutralize TNF, and as a result, inflammatory response would be interrupted. And you have four kinds of therapy blockers which are available: infliximab, adalimumab, certolizumab, and golimumab. Now, it was seen that IL-12, which is a major cytokine of Th1, has two subunits, P40 and P35. IL-23, which is a major cytokine of Th17, has two subunits, P40 and P19. So if you have a P40 blocker, obviously it will block both Th1 responses and Th17 responses. So obviously you are blocking two major pathways. So came up ustekinumab. Ustekinumab is available in the country, and it is basically a P40 blocker, so it blocks both IL-12 and IL-23. What was seen was that if you blocked only IL-23, which is a cytokine of Th17, that is, you have a P19 blocker, then also inflammation could be clearly mitigated, and so have come up two monoclonal antibodies, risankizumab and mirikizumab. That is how the landscape of treatment has been changing across in IBD. Then the next concept was that there are lymphocytes which are in the blood. They go to the lamina propria, which is the site of inflammation. These are the epithelial cells which are lining the villi, and these are villi, the epithelial cells which are lining the lumen, and these are the villi out here. So for the lymphocytes to reach the battlefield, that is the site of inflammation, they have to cross through the endothelium. How do they cross through the endothelial wall? Lymphocytes have alpha 4 beta 7 receptors on them. MADCAM is the receptor on the endothelial cell. So when there's an interaction of alpha 4 beta 7 with MADCAM, the lymphocyte can squeeze through the endothelial wall and go to the site of inflammation. So if you have a lymphocyte tracking inhibitor like a alpha 4 beta 7 integrin inhibitor, which is known as vedolizumab, the lymphocytes will not be able to interact with MADCAM receptor, will not be able to reach the site of inflammation. So came up vedolizumab, or the lymphocyte trafficking inhibitor. Subsequently, another drug came up. What if we prevent the lymphocytes from leaving the lymph nodes? The lymphocytes are activated in the naive lymphocytes, they go to the lymph nodes, they are activated out there. Then subsequently, they go to the site of inflammation. How? There's a sphingosine 1 phosphate receptor, and there's a gradient of that, and sniffing that gradient, the lymphocytes reach the site of inflammation. If you modulate this sphingosine 1 phosphate gradient, the lymphocytes will not be able to sniff the gradient. They'll not be able to reach the site of inflammation. They'll not be able to come out of the lymph nodes. So came up a molecule known as ozanimod. Ozanimod is a sphingosine 1 phosphate receptor modifier. So as a result, the lymphocytes are not able to leave the site lymph nodes at all. So we find that there are a lot of extracellular targeted pathways which are available. That is in the form of TNF inhibitors, IL-12, IL-23 inhibitors, alpha 4 beta 7 integrin inhibitors, which are preventing lymphocytes from coming here. Here lymphocytes cannot act because of TNF inhibitors, IL-12, 12, 12, 23 inhibitors, but they're all extracellular. How can you, once the lymphocyte reaches out, can you have something which blocks intracellular signaling? So came up another class of drugs which are known as Janus kinase inhibitors, JAK inhibitors, which block the lymphocyte intracellular signaling. Any cell, what will happen is on the cell membrane, there are many receptors to which the cytokines will come and attach. Interferon gamma 2, 6, any cytokine which has to act will come and attach to the cell membrane, and there it will there it will interact with Janus kinase pathway, the JAK-STAT pathway. JAK-STAT pathway, once it gets activated, it leads to moves on to the nucleus where the transcription of pro-inflammatory factors would take place. But if you have a blocker of this intracellular signaling pathway and that can be done with the help of tofacitinib, all these inflammatory signals will not mature, and so came of tofacitinib. Now, tofacitinib is a pan-JAK inhibitor, JAK1, JAK2, type 2. So if you wanted something more specific, you have only a pure JAK1 inhibitor, which is known as upadacitinib. Upadacitinib is again a JAK inhibitor, but it is a selective JAK inhibitor in the form of JAK1. So you find that there are a lot of therapies which are available for both ulcerative colitis and Crohn's disease. All of them are FDA approved except filgotinib, which is European agency approved but not FDA approved. And if we go through them, we find that infliximab, adalimumab are effective in both ulcerative colitis and Crohn's disease. Golimumab, which was a TNF alpha blocker, is effective in ulcerative colitis but not in Crohn's disease. Certolizumab, which was a TNF blocker, again was effective in Crohn's disease but not in ulcerative colitis. Vedolizumab is effective in both ulcerative colitis and Crohn's disease. Ustekinumab is effective in both ulcerative colitis and Crohn's disease. Tofacitinib is effective in ulcerative colitis but not effective in Crohn's disease. Very important point to remember. Upadacitinib is effective in both ulcerative colitis and Crohn's disease. Risankizumab is effective in Crohn's disease. Risankizumab was a P19 inhibitor, an IL-23 inhibitor only. And similarly, miracuzumab is effective in patients with ulcerative colitis. Ozanimod, as I showed you last slide, is effective in patients with ulcerative colitis. So we find that there are two kinds of drugs which are available: ozanimod, tofacitinib, upadacitinib, filgotinib, etc., and the rest. What is the difference? These are all monoclonal antibodies, infliximab to ustekinumab and mirikizumab. Anything which has a mAb is a monoclonal antibody. The NIBs, they're all JAK inhibitors, but they're oral small molecules. Ozanimod is an oral small molecule. What is the difference between them? The biologicals, they are complex proteins, whereas the oral small molecules are hydrocarbons, easy to prepare. They can be stored anywhere at room temperature. They don't require refrigeration. The cost is low. The route is oral for small molecules compared to biologicals, which are to be given IV or subcutaneous. The biologicals have a slower onset of action. The oral small molecules have a faster onset of action, and obviously the patient comfort would be better for oral small molecules. The site of action would be intracellular for oral small molecules. There may be more adverse events with oral small molecules. The drug-to-drug interactions are also more frequent with oral small molecules. But remember, despite so many drugs, there is what we call as a therapeutic ceiling. In other words, these drugs are not curative or something like that. At the same time, most of these advanced treatments, they report clinical remission at year of 30 to 50%. They are not giving you a 100% response. And why is it so? Because there is a redundancy of immune pathways. There are too many immune pathways. There's not one immune pathway which you block and that will help. There's a redundancy. So blocking one pathway will not help. In fact, in a recent review in New England Journal of Medicine, the first line was that although there are many therapies available but they cannot cure IBD. And that is what we have to be cognizant of, that we have so many molecules which are available, the antibodies as well as the oral molecules, yet you can only control inflammation. You are not able to eradicate the disease. When do you go on to these advanced therapies? The classical indications are in ulcerative colitis if there is a lack of efficacy of the regular treatment using steroids or immunomodulators, so steroid-dependent disease or refractory pouchitis. That is, the patient has undergone surgery, ileal pouch anal anastomosis, and despite that, the patient is having a lot of inflammation in the pouch. Crohn's disease, again, lack of efficacy of classical treatment using steroids or immunomodulators. There are certain cases of Crohn's disease where you would go for a top-down therapy. I'll explain it to you later. And then third is after surgery also, there's a high chance of recurrence in case of Crohn's disease. So sometimes you end up giving biologics and oral small molecules. When not to give? When there's an active infection, untreated tuberculosis, and even in active malignancy, it remains a plus minus thing in terms of whether you would like to start these agents or not. Anti-TNF, the definite contraindications are demyelinating disease or congestive cardiac failure. JAK inhibitor, definite contraindications are thromboembolism and elderly with coronary artery disease or CVA. Relative contraindications are child C cirrhosis or chronic renal failure. Vedolizumab and ustekinumab, apart from these main contraindications, there are no other contraindications as such. Now, two slides on surgery. Remember, in ulcerative colitis, surgery can be curative. Why curative? Because there is no recurrence after surgery in a definite case of ulcerative colitis. However, the problem with surgery is that it is not a one-step surgery. It's either a two-step surgery or a three-step surgery. First step, what is done is a colectomy is done, and subsequently a diverting ileostomy is made. Or in the first step, only a pouch can be made. But generally, people after if a patient has been on biological therapy, would prefer to do a three-step surgery because the adverse events are much less after three-step surgery. So, first step is colectomy, subtotal colectomy with a Hartmann's pouch, and the second step is formation of ileal pouch, and third step is closure of the ileostomy so as the continuity is maintained. So as I told you, because it's a three step, so that is a problem. Second is that the results 80 to 90% of patients do very well, but 10 to 20% of patients do have problem in form of either anastomotic strictures, recurrent pouchitis, pouch failures, pouch fistula. So although surgery is curative, but I would say surgery has a learning curve, and that is why still people try to sequence a lot of medical therapies before moving for surgery, which again requires a lot of judgment. In Crohn's disease, you have to understand there's an opposite view out. The opposite view out here is that surgery is not curative in Crohn's disease. In Crohn's disease, even if you operate, remove away the disease segment, there's a good 80 to 90% chance that over a period of 5 to 10%, the patient would definitely have recurrence. Only 10 to 30% of patients never have a recurrence. Otherwise, majority of them would have a recurrence, which would be endoscopic recurrence, radiological recurrence, or even requiring a second surgery. So that is why surgery is again although attractive option in Crohn's disease. But remember, even after surgery, a case with Crohn's disease, you have to give prophylactic immunosuppressants so as to reduce the recurrence of the disease. Ulcerative colitis, when we talk about sequential therapy, there is one approach only, that is a step-up approach. Step-up approach is you start with level 1 drugs like aminosalicylate. Patient is not responding, go on to corticosteroids. You only start corticosteroids if the patient straight away starts with very severe disease. Otherwise, you start with aminosalicylate and gradually step up the treatment. You do not start with biological straight away. Starting straight away with biologicals in a case of ulcerative colitis has not been found to be useful. So if you have a patient with mild to moderate ulcerative colitis, you will start with proctitis. As I told you, involves only the rectum. So you will start with suppositories, 5-ASA suppositories, steroid enemas, etc. And if the patient does not respond, move over to oral 5-ASA. Left colitis and pancolitis, you will give suppositories. At the same time, if you want to start steroids, you may start with second generation steroids, that is budesonide MMX, which gets released only in the colon. And if the patient is not responding, then move over to oral steroids. If a patient has a severe disease, moderate to severe disease, in all three cases, you will start with oral steroids. So again, if a patient has mild to moderate ulcerative colitis, you start with oral 5-ASA or topical 5-ASA, and thereafter, if there's a relapse, you can move over to budesonide MMX. Still, the patient is not responding, move over to systemic steroids. Steroid-dependent disease, so I always add azathioprine. If the patient is intolerant to azathioprine or not responding to azathioprine, then you move over to the advanced therapy, which we just now discussed. So you have a whole range of choices out here. So in a case of ulcerative colitis, which are the best agents? Well, it seems that infliximab is a very excellent agent. Vedolizumab is an excellent agent. Adalimumab is inferior to infliximab and vedolizumab in this setting. Surgery is obviously a great choice. Tofacitinib has excellent results in ulcerative colitis. Similarly, ustekinumab has excellent results in ulcerative colitis. In a case of ulcerative colitis, again steroid dependent, no response to azathioprine, but he's elderly, prone to infection. This is the kind of subset or recent malignancy. There, in those cases, vedolizumab and ustekinumab are preferred. Why? Because they are very safe drugs. So the safety ratio factor is very high. Patient of ulcerative colitis with extraintestinal manifestations, no response to IV steroids. Again, you have to understand the nuances that vedolizumab will not be effective in this case. I told you that for ulcerative colitis, vedolizumab is a good drug. But at the same time, if the patient has EIMs, they will not get treated with vedolizumab. They will get treated with infliximab, adalimumab, tofacitinib, or ustekinumab. If a IBD with pregnancy, you can give any of these agents. tofacitinib is something which is to be strictly avoided in a patient with pregnancy. Right? And tofacitinib again is not useful in a case of Crohn's disease, but upadacitinib, which is another JAK inhibitor, is useful in a case of Crohn's disease. So in a case of Crohn's disease, no point starting tofacitinib. Acute severe ulcerative colitis, that is a patient which comes with more than 6 bloody stools per day, with either tachycardia or raised temperature or anemia or an increased ESR. There you would hospitalize the patient. Why would you hospitalize the patient? Because the patients there, the mortality rate can go up to 5% or something. So it is very necessary that you immediately act. What do? You always get an abdominal X-ray done to rule out toxic megacolon. You always get a stool for C. diff done. Do an unprepared sigmoidoscopy again by to look for the inflammatory features in the colon. At the same time, you also take a rectal biopsy for cytomegalovirus. You can start the patient on IV steroids, hydrocortisone 100 milligrams 6 to 8 hourly. Antibiotics may be given in certain cases. Prophylactic heparin has to be given in all cases, and you may also add exclusive enteral nutrition. You give steroids for 5 days, assess the response at 3 days, and depending upon the response, you can decide whether the patient is non-responder or a complete responder. Why it is important? Because those patients who are not responding at day 3, there's a high chance that they would move on to second line therapy. What is the second line therapy? Second line therapy is biological or cyclosporin or surgery. These are the 3 options which are available till now. Now, tofacitinib has also been used in this setting and it has been found to be useful. So, if you have a choice that is at 5th day patient is not responding, you can exercise any one of these 3 options depending upon the situation. The biological which has to be used in this setting is infliximab, and infliximab has been found to be as useful as cyclosporin, whereby you can give an infliximab, cyclosporin, assess the response in 7 days. So ASUC, acute severe ulcerative colitis, no response to IV steroid, you can use infliximab, you can use cyclosporin, you can use tofacitinib, you can also send the patient for surgery. Whereas adalimumab, vedolizumab, ustekinumab will not be helpful in this kind of situation. Crohn's disease, remember, there's one distinction as compared to ulcerative colitis. In some patients, you go for straight away, you move for a top-down therapy. That is patients which have very aggressive disease. The markers of poor prognosis are younger age, complex perianal fistula, early stricturing penetrating disease, extensive small bowel disease or upper GI disease. So as I told you, step-up therapy is something which you use for ulcerative colitis. In Crohn's disease, you can do step-up therapy. There are certain select case scenarios where you perform a top-down therapy. What do we mean by top-down therapy? Top-down therapy, we mean that you start with straight away biological agents. You don't go through that step climbing up scenario that you start with 5-ASA, wait for the response, no response, steroids, wait for the response, no response, then add azathioprine, more move over to biological agents. Straight away, you start with biological agents. Which are these conditions where you step up the therapy? Patients have an inflammatory phenotype, B1 kind of disease, non-stricturing, non-penetrating, or colonic disease. Whereas the markers of aggressive disease, which I told you just now, any complex fistula, stricturing disease, extensive small bowel disease, upper GI disease, you'll straight away start with biological therapy. So if it's an inflammatory disease, there is low risk for progression, step-up therapy. You have to control inflammation. You can start with sulfasalazine, induce remission, and mesalamine, although as I told you, evidence-based guidelines suggest they don't have any role, but real-world evidence, mesalamine has been found to be useful in mild Crohn's disease, right? And the preparation can be 5-ASA small intestinal release if the disease is affecting the ileum, and sulfasalazine if the disease is affecting the colon. Similarly, if the patient has perianal fistula, you know there's a high risk for progression. So here you would like to start with top-down therapy. Multidisciplinary care is required for most patients with perianal fistula or any enteroenteric fistula or stricturing Crohn's disease. You have to decide whether the patient has a simple fistula like this or a complex fistula. You have to give top-down therapies. A surgeon has to be involved. So how do you decide a patient has simple fistula or complex fistula? If it is a low origin, low transsphincteric, single external orifice, no abscess, no rectovaginal fistula or anorectal stenosis. Whereas if there are multiple external orifices, there is a perianal abscess out there, it is a high fistula, or it has associated with rectovaginal fistula, then you know it's a complex fistula. And if it is a complex fistula, you have to take care of infection with the help of antibiotics, ceton drainage has to be done, and then you can give anti-TNF. Best is infliximab has the largest amount of data, and maintain with infliximab and azathioprine. If it's a simple fistula, then you can do and give antibiotics and do a fistulotomy, right? So in Crohn's disease, again, you position your biologicals, but what is seen is that infliximab and adalimumab both are effective in cases of Crohn's disease. At the same time, ustekinumab, upadacitinib are also very effective. Vido is effective, but in for patients who have a high degree of inflammation, infliximab, adalimumab, ustekinumab, and upadacitinib, they do score. They do perform much better. If it's a fistulizing Crohn's disease, then infliximab, adalimumab, and ustekinumab, they score very well. If the patient has had a prior non-response to anti-TNF, then obviously you have plenty of choices available today in form of ustekinumab, upadacitinib, or vedolizumab. And similarly, as I told you, if the patient is elderly, the safety issue is very major, then in those cases, ustekinumab or vedolizumab can be used as first-line therapies. Sometimes it happens is that you are treating the patient, still the patient is not responding, then you have to check for things. The things you check for is you see if the patient has any superimposed infection, which may be cytomegalovirus infection or Clostridium difficile infection. If the patient is a steroid or biological, they may have superimposed TB infection. If there's a long-standing colon disease, there's a chance of colorectal cancer development. So whenever there's a discrepancy in terms of the symptoms and the signs, and at the same time, best is to repeat a sigmoidoscopy to assess if mucosal activity matches the clinical symptoms. For example, you may find ulcers and you take a biopsy. Real-time PCR for them is positive for CMV DNA, or you may at times even find intracellular inclusions positive for CMV. Obviously, this patient has a CMV superinfection and needs to be treated with IV ganciclovir or oral valganciclovir. Clostridium difficile is commonly superimposed, so you would like to test it with two-step test. That is, step one is do a GDH, because GDH is very sensitive, and if GDH is positive, then you do a toxin A and B. And sometimes people end up doing only toxin A and B. Toxin A and B are very specific tests, but at the same time they would miss many cases of Clostridium difficile infection. So best is to do a combination of GDH and toxin A and B. And in long-standing Crohn's colitis or ulcerative colitis, particularly pancolitis and left colitis, ulcerative colitis, and Crohn's colitis, if it is involving more than one-third of colon. If the disease duration has been more than 8 to 10 years, do screen for colorectal cancer, because both these diseases can lead to malignancy. And pancolitis, increased duration of disease, primary sclerosing cholangitis, persistent inflammatory activity, pseudopolyps, or family history of sporadic colorectal cancer, all can give a high chance of colorectal cancer. So finally, concluding, I would say that I've given you overview of what are the various factors which you need to know, or various things which you need to know about the patient before you decide about the management. And that is for ulcerative colitis and Crohn's disease. I give you a brief overview of that, and I also gave you a brief overview about the landscape of therapy which is available, so that there are plenty of choices available and there are many nuances in terms of how you're going to sequence the therapies. Thank you so much for your attention, please.
Thank you, Dr. Vineet, for excellent talk. In just 1 hour, 15 minutes, we have covered a huge topic which people cover in 2-day or 3-day conferences. So I think we welcome questions on the chat box from the audiences. So till we get questions, just few thoughts or comments from you on regarding issues of IBD in a young female who is planning to become pregnant, issues for her regarding the sequence of IBD course in during her pregnancy, and issues for the upcoming fetus, and also pre-pregnancy fertility issues, which are quite common in patients with IBD.
So pregnancy can exacerbate IBD disease activity. So the first thing is that we have to ensure that the patient has remission of the disease. So pregnancy, the counseling prior to that is very important. There are two things which are necessary in counseling. First is to give confidence to the patient that fertility rates are not decreased in cases with IBD. They can go ahead and plan a successful pregnancy. Most of the patients, they avoid pregnancy because they're afraid, either or because of the disease or because of the treatment they are taking, and they feel that that would have an adverse effect on the fetus. So foremost thing is to inform them, provide them with the knowledge that successful pregnancy can be achieved in a case with IBD. One. Number two, the immediate thing which has to be done before going in for conception is having 3 to 6 months of disease which is in remission, because that is the most important factor which will again decide what is going to be the outcome of pregnancy as well as the outcome of the disease during the pregnancy. Third thing is that if a patient is on azathioprine, it can be easily continued because most of the gynecologists or obstetricians, they would be stopping azathioprine. However, there's plenty of data available which shows that azathioprine can be continued during pregnancy. If a patient is on biological, the biological can also be continued through all the 3 trimesters of pregnancy. We have data available worldwide which shows that infliximab is safe in pregnancy, adalimumab is safe in pregnancy. For ustekinumab and for vedolizumab, initial data has already come up which again suggests that it is safe. Tofacitinib and upadacitinib are 2 drugs which are to be totally avoided 3 months prior to conception. Similarly, methotrexate should be avoided prior to conception or during pregnancy. Then the next thing is that most patients can have a normal vaginal delivery, except patients who have had perianal fistulas. In those cases, they may have to undergo LSCS. Then immediate for as far as the baby is concerned, if the patients have been on biologicals, then you would not like to give live vaccines to the baby immediately after birth. The live vaccines generally are the BCG or the oral polio, and that is something which you would like to avoid. The outcomes are there would be a slightly higher rate of stillbirths, there will be a higher rate of preterm delivery, there would be a higher rate of low birth weight. Yet at the same time, majority of the women, they achieve a successful outcome for pregnancy, have a safe delivery, and also the fetal outcomes or the neonatal health is also often very good.
So the second issue is regarding the role of surgery. Yes, in ulcerative colitis, we had so many options which are quite successful. So surgery is a last resort, obviously. In Crohn's disease, there was recent data that upfront surgery for, say, limited ileocolonic disease with limited EIMs and limited other disease activity can be offered surgery upfront as compared to expensive biologicals.
Yeah, that's an excellent question which you have raised. So in Crohn's disease, often surgery, people try to avoid surgery unless until it's a stricturing fistulizing disease, because after surgery, the disease does reoccur in a majority of cases. However, in limited ileal disease, when disease was limited to less than 40 centimeters, a Dutch trial showed, randomized control trial known as a lyric trial, showed that when they randomized patients who were steroid dependent to biologicals versus surgery, the patients who were on biologicals, they had a poor quality of life as compared to patients who underwent surgery. That was the 1 year data. Subsequently, the 3 to 5 year data which came up showed that majority of patients of infliximab either had to intensify their dose or they had to undergo surgery, whereas 1/4 or more than 30 to 40%, I think around 30% of patients of surgery, they never had to undergo any dose of biological at all, suggesting that this is the excellent intervention which can be done in L1 disease. 2 months back, a population-based study also came up in gastroenterology, which suggested that when they looked at the population data and they found that all those patients who had undergone surgery where ileal resection was done, they were performing much better than patients of ileal disease who were on biologicals. So, and the third thing for our country is that often we tend to confuse between tuberculosis and Crohn's disease. So there's limited ileal involvement and there's a stricture and you're not able to differentiate. Then doing surgery is theranostic in the sense that it diagnoses as well as.
So next important question is regarding diet in IBD. You have done a lot of work of diet in IBD, different kinds of exclusion diets like enteric exclusion diet, partially enteral nutrition, Mediterranean diets, and then the role of low FODMAP diet, particularly in patients who have got IBS-like symptoms in the period when they are actually having a remission. So few IBS-like symptoms may persist. So any role of dietary therapy during that period or during the acute stage?
So diet is low FODMAP diet. may be useful, particularly if a patient has IBS with IBD. Many of these patients of IBD, they have abdominal distension, bloating, or increased stool frequency, but they don't have blood in stools. You do a fecal calprotectin, that is normal. Do a sigmoidoscopy, that does not show increased activity. Then you know that there are features of IBS. So in such cases, a low FODMAP diet may be essential, but that is only for IBS with IBD. When we talk about treating IBD with diet, then the best data is for exclusive enteral nutrition in pediatric Crohn's disease, where it has been found to be as effective as steroids for treating Crohn's disease. Subsequently, in adults also, you have now data which shows that exclusive enteral nutrition is helpful in improving the response of biologics, because not only it has an anti-inflammatory effect, but it also increases the albumin levels, which helps to improve the response of biologics. Besides that, there is anti-inflammatory diet. We have done more work on anti-inflammatory diet rather than Mediterranean diet, because we feel that for our country, anti-inflammatory diet is something which is easy for people to procure, get, take it, and also does not add to the cost. A Mediterranean diet would be something which will not be practical for majority of the Indians. Like, you can't ask them to take olive oil or something like that. So here, anti-inflammatory diet basically means that you avoid milk but take curd or buttermilk, etc., in large amounts. You avoid gluten, but you can take rice, maize, etc. You avoid processed food or ultra processed food, but you take fresh fruits and vegetables. You can take non-vegetarian food, but do not take red meat. In the sense, avoid red. So these are the 3 or 4 major principles, and anti-inflammatory diet possibly has a role. One cannot be very conclusive about that it is something which is has to be done. But yes, data is emerging that it possibly does help.
So there are a lot of physicians in our audience or budding physicians. So they also encountered questions regarding post pouch. So what are the normal frequency of stools post pouch, and what is considered abnormal, and how do you early have a clue that patient might be developing early stage of pouchitis, and what are the therapeutic options for these patients?
So patients of ulcerative colitis, the surgery which is done is ileal pouch anal anastomosis. From terminal ileum, a pouch is made so that it can replicate the reservoir function of rectum. In cases with Crohn's disease, the pouch is not made. You have a ileorectal anastomosis if you have to do anything, because if you make a pouch, invariably there is a recurrence or inflow of inflammation out there. Now, in a case of ulcerative colitis, when a pouch is made, 80% of patients do very well. They may have a stool frequency maybe from between 5 to 10, but that is, they do not pass any blood in the stools, and they do not require any additional therapy at all. And their quality of life is excellent. 10 to 20% of cases do have problems, and most of the time, these are those cases who have had a prolonged medical therapy courses and many failures of medical therapy, where the decision to send them to surgery was not taken at the appropriate time. So in those cases, they may have either an increased frequency, which may be more than 10 or something. They would have recurrent pouchitis, which could be acute pouchitis, move over to chronic pouchitis. Pouchitis means that they would be passing blood in stools. If you go ahead and do a pouchoscopy, you will find that there are ulcers out there. You'll take biopsy, there would be a neutrophilic infiltrate out there. So those are initially managed with antibiotics. They are antibiotic responsive pouches, there are antibiotic dependent pouches, and there are antibiotic refractory pouches. When the pouch becomes antibiotic refractory, then you have to move over to immunosuppressive therapy in the form of steroids. A very occasional case, biologicals have also to be given. Then there are certain cases where initially a distinction of ulcerative colitis patient looked like a case of ulcerative colitis, but could be having IBD-U, as I said, IBD unclassified. There again, if you make a pouch, the chances of pouch failure or pouch complications are high. Sometimes immediately after surgery, fistulas form in the pouch. That is because of the surgical issue, that there could be inflammation or there could be something as a result, or there is some dehiscence and anastomotic leak, which lead on to pouch fistula. So they have to be surgically corrected, because in those kind of conditions, the biologics or anti-inflammatory drugs are not going to help.
So another important practical question is EIMs, like extraintestinal manifestations are present to the tune of 20 to 40% in UC and Crohn's. And one of them is rheumatological manifestation in form of arthritis, central or peripheral. So how does the choice of drugs change once the person comes with bowel plus EIM and bowel without EIM?
So I had a slide in between which
Yeah.
showed that when there's a bowel with EIM, then in that case, infliximab may be useful, adalimumab use may be useful, tofacitinib may be useful, ustekinumab probably yes, but vedolizumab will not be useful. Surgery would not be useful. So
So
if you have a patient with, let us say, ang spot, there again infliximab or adalimumab may be given as it is, even if the patient had only ang spot and had no bowel symptoms. So there you can use it. Similarly, if the patient has as a addition psoriasis, so you can give tofacitinib. It will take care of both psoriasis as well as the bowel symptoms. So the main biologicals infliximab, adalimumab, and the oral small molecule tofacitinib, your choice will veer towards these three if the patient has extraintestinal manifestation. Again, if it is primary sclerosing cholangitis, then none of these biologicals or oral small molecules would be useful. There you may have to give vancomycin in addition. That also may have provide you with marginal benefit. So there are certain EIMs which respond along with the disease. So they're using these biologicals and all.
So next question is, in India, since hepatitis B in normal population is to the tune of 3 to 4%, so IBD patients are no different. So they are going to have similar percentage indeed. So what is the protocol or approach to patients who are, say, HbSAg negative plus only anti-HBC positive, and you are planning to start biologicals or other immunomodulators?
So best is, I think, is that best would be to do HBV DNA, but I think a better approach than that would be to do an anti-HBS, because from last 10, 20, 30 years, 25 years or something, like, there has been definitely universal immunization of hepatitis B started in many states. So if a patient comes to you, if you HbSAg negative, anti-HBC, total anti-HBC positive, the simple thing would be to do anti-HBS. If anti-HBS is positive, you can give anything. Suppose you don't want to do anti-HBs and you do a HBV DNA. And if HBV DNA is positive, then in that case, if you are starting biologicals, you may have to start along with that. Antivirals would have to be started. For example, if it is rituximab, then even with anti-HBC only positive, people end up starting with antivirals. Whereas, but for infliximab and adalimumab and all, unless until HBV DNA is positive, you would not start antivirals.
So next question is regarding like treat to target approach, like as against the standard step up approach. Treat to target approach is obviously preferable, but is haunted by the cost factor. So whom do we offer it all the patients or selected patients where the risk of progression, future
First of
progression
all,
or relapse is high?
First of all, let's make the distinction between ulcerative colitis and Crohn's disease. Although the stride to consensus says that you should have a universal treat to target approach, but at the same time, there are commentaries coming up against this kind of viewpoint. The reason being that in ulcerative colitis, there is as yet no randomized control trial available which has shown the benefit of treat to target approach. Early use of biologics within first 2 years has not been shown to change the natural course of disease in cases with ulcerative colitis. So in ulcerative colitis, you need not apply a treat to target approach. At least the evidence is not backing it up. Viewpoints may be backing it up, but there is no evidence in form of RCTs, etc., to back it up. In Crohn's disease, there are only two trials which are available. That is the CALM trial and the REACT-2 trial, which have suggested that yes, treat to target may be beneficial. And secondly, in Crohn's disease, early use of biologicals within 2 years of the onset of disease has been found to be useful in changing the natural course of disease. So in a case of Crohn's disease, you maybe would like to, if the patient can afford, and if you can step up the therapy, if the patient has, let us say, not responding to initial first line therapy and shows endoscopic activity or radiological activity, because you would like to stop the progression of the disease.
So most of us attending this CME are MD medicine people, but I think there are few pediatricians are also attending. So they would like to have your views on very early onset pediatric IBD as well as monogenic IBD. When should a physician or a pediatrician suspect the IBD to be monogenic?
So very early onset IBD is less than 6 years. Infantile IBD is like less than 2 years. Infant is 1 year, but infantile IBD is less than 2 years, right? So the earlier it starts, the more chances of it being monogenic. So if you check for if a child has had IBD less than 2 years, there's a high chance that the child could be having monogenic IBD. So you should test for it. Besides that, other features, or less than 6 years, again you would have a high chance. But as you go up the age, the chances of it being monogenic decrease. There are other features which help you raising the suspicion of monogenic IBD. That is, if there's a family history with very strong, very aggressive IBD, perianal fistulae which are there, IBD not responding to regular therapy, then extraintestinal manifestations are there, then you know that the possibility of monogenic IBD is there.
So next question is regarding the biological, since we are resource limited country. So a patient with IBD, either UC or Crohn's, doing well for say 2 years, absolutely free of relapse, and nutrition and other parameters also well maintained. Can we think about de-escalation, particularly of biologicals?
Yes, you can de-escalate. You can de-escalate provided, number one, look at the past history of the patient and also look at the present status of the patient. When you look at the past history of the patient, if the patient has had a very aggressive disease course, let us say perianal fistulizing disease, enteroenteric fistula, 2, 3 surgeries, still again, so then you know that the chances of recurrence are very high. Then look at the present state. Present state, if there has been clinical response as well as endoscopic response, or if it's a case of small bowel Crohn's disease, radiological response, then you can think about stopping biological. If the patient does not have a very aggressive past course and right now clinical and endoscopic response, your chances of maintaining success, that is response success after stopping biologicals are high. But again, do not stop, or if the patient is not on azathioprine, start azathioprine or methotrexate, or do not stop that and just stop the biological.
So next three questions are also regarding biologicals. One is the use of combination of biologicals in difficult to treat patients. Second is switching of biological from one class to the other or intra-class. And third is regarding the role of therapeutic drug monitoring. Is it should be proactive or should be done only in case of patients who are not getting treated?
First was the first question.
Combination of biologicals in the
Question
patient
is
not
that
responding, short of sending them
infliximab,
to surgeon.
infliximab and adalimumab, they have been associated with formation of anti-drug antibodies. So as a result, they lose their response after a certain period of time. All biologicals are proteins. Yet at the same time, the number of antibodies to vedolizumab and ustekinumab is much lower in proportion compared to infliximab and adalimumab. So with infliximab, whenever you start, you would always like to add azathioprine or methotrexate in low dose, give it for 1 year or 2 years. Adalimumab, again, you would like to add azathioprine or methotrexate, give it for 1 year or something. With Vedolizumab and ustekinumab, you do not add azathioprine or methotrexate to reduce the immunogenicity. However, in refractory cases where the response is not good, there you may consider adding. Now, how do you decide whether a biological is working or not? That is with the help of therapeutic drug monitoring. Therapeutic drug monitoring can be proactive or reactive. Proactive is that you decide every 3 months, the way you do a complete blood count, I am going to monitor the drug levels. And if the drug levels are low, I am going to increase the drug dosage. Reactive is to do a drug monitoring when you find that the patient is not responding. That at that time, I want to measure the drug level and the antibody level. It has been seen that both strategies are equally effective. It is not that proactive approach is superior to reactive approach. So when you measure the drug, when if a patient is not doing well, that is the reactive approach, you measure first the drug level. If the drug level is high, then there is no point in doing a antibody level, no point wasting money on antibody level, because that itself tells you that you need to change the drug, you need to change out of class for that drug. If the drug levels are, let us say, low, then you can do an antibody level. If the antibodies are low, then you can increase the drug dosage or you decrease the frequency of drug administration or add immunomodulators if they were not there along with that. If the drug levels are low and the antibody levels are high, then you know that you have to change within class or out of class, you can do that. So that is the way you will do that.
And next question is regarding addictions, which are quite common. Maybe they are in patients with IBD as well. Of course, smoking is to be stopped by Crohn's disease at the first meeting itself. The other addictions like alcohol and smoking, what are the advices to be given?
So smoking, even though it is beneficial, shown to be beneficial in cases of ulcerative colitis, but because of its ill effects on other organ systems, so smoking has to be stopped, right? Alcohol, again, is not beneficial. However, it is not that the patient cannot drink at all, like social drinking and all. If the patient has been taking it, it will not have any effect on the disease activity. More important addiction out here is the opiate addiction. Some of these patients of Crohn's disease, they have pain and they get addicted to opiates. And that may lead on to either a narcotic bowel syndrome. And surprisingly, there's a phenotype which is being seen in Rajasthan. It is not being reported from Rajasthan very frequently. Is patients who have opiates, those who have narcotic bowel syndrome, they do not never develop stricturing disease. However, in India, patients who are only on opiates, they develop a stricturing disease. So some of these patients who are opiate addicts, they come and they are diagnosed as having Crohn's disease, whereas actually they were only opiate addicts. So they end up being labeled as refractory Crohn's disease, being on various biologicals, whereas actual diagnosis has been opiate addiction. So that is one thing which physicians and gastroenterologists should be aware.
So the last three questions are regarding the upcoming therapies with not so much data available. That is the role of hyperbaric oxygen therapy, role of FMT, where you have done quite a lot of work, and mesenchymal stem cell therapy for refractory fistulas.
So for all these three things, we have done the studies and published the studies. Hyperbaric oxygen therapy, we did a case series rather than a randomized controlled trial, and it was seen that it was effective in cases with fistulizing Crohn's disease, enteroenteric fistulas. It is also effective in cases with perianal fistula, but then again, as 20 to 30 sessions are required. It is not that you only give 5 to 10 sessions. So it is a good, if the hyperbaric oxygen chamber is available and particularly available in government hospitals and the cost factor is not there, then it is a good therapy for patients who cannot afford other costly drugs. FMT is not been FDA approved, but at the same time for ulcerative colitis, at least 7 or 8 randomized controlled trials are available, for 5 meta-analyses are available, which have shown that it is useful in patients with mild to moderate ulcerative colitis. And third is the mesenchymal stem cell therapy. We've just completed a phase 1-2 study of 10 patients where mesenchymal stem cells were injected in perianal fistula, and the response rates were quite decent, to the tune of the response rate was 70%, the remission rate was 20 to 20%. But these are those cases which are refractory to other treatments. And once they got a response, the response remained for 1 year.
So the last thing is toxic megacolon. So we do monitor the patient for toxic megacolon in ASUC. So once we see it, immediately it is to be handed over to surgeon, or you can still try. We had limited experience at GB Pant of 17 patients. Of course, we should not quote it, not published. 17 patients who responded to infliximab and surgery was avoided. So what is your experience on that?
That is a unique experience from GB Pant, right? And since you have shown it, definitely in the sense that quite possible that you used it early on before the toxic megacolon fully set in. So at our center, we immediately involve the surgeons. May not the send for surgery immediately, but yes, the joint consultations start, and depending upon the situation of the patient, in 48 to 72 hours, you do decide either way, whether the patient is improving fine, otherwise the patient goes in for surgery. So biologicals, we are not giving in toxic megacolon. Again, I think this is something which can be further explored upon.
Yeah. So Dr. Nishika, any further questions from your side? I can't see more on chat box.
Okay, sir. If there are no more questions, I would like to thank the distinguished speaker for this evening, Dr. Vineet Ahuja.
So I do not know the feedback about the audience, but I give 10 out of 10 marks. And excellent talk to Dr. Vineet. Thank you so much.
You are always very kind. You had such a learned chairperson that I enjoyed the discussions with Sanjeev a lot.
Thank you, sir.
Thank you, sir. On behalf of the National Academy of Medical Sciences, it is indeed my great pleasure to thank the distinguished speaker for this evening, Dr. Vineet Ahuja, sir, for covering this complex issue of inflammatory bowel disease in a very simple way, as sir said. And I'm sure that the practical tips you have given to the student as well as the participant will be very useful. Thank you, sir, and we look forward for your support in future also.
Thank you.
Special thanks to Dr. Sanjeev Sachdeva, sir, for chairing the session, moderating the discussion, and generating a lot of discussion. Sir, thank you so much for your support, and we look forward for a blessing in the future.
Thank you.
In the participants, sir, we have noted the principal, Government Medical College, Gantur, along with the student, director, RIMS, Raichur, as well as the principal from the Government Medical College, Kathua, along with the student and the faculty. So special thanks to them, along with all the participants who have made this session very interactive by asking questions. And we hope that you have enjoyed this session. Just for your information, that the next session in the series on gastroenterology is due on 19th of January at 3 p.m. And there we are going to cover a very interesting topic of chronic diarrhea and malabsorption. And there again, very eminent speaker, Dr. Govind Makharia sir is going to take that session. So I will also like to place on record the support we have got from Makharia sir by identifying the best speaker as well as the topic. He has been the chief coordinator for this series. So once again, I would like to thank Dr. Preeti, who has been helping us in organizing this session, as well as the IT team from NAMS, Mr. Ravi, for sending you emails and ensuring that this transmission is done properly. So once again, thank you so much. Wishing you all Merry Christmas and New Year. See you in the next session, which is on 19th of January. In between, we have another very interesting session on 5th of January at 3 p.m., where the experts are going to discuss antimicrobial resistance, what are the challenges and issues. So I will request all the participants to join. We are going to share the Zoom link and all the details very soon. So thank you once again, and good night. Namaskar.
Thank you. Thank you, sir.